one of the interesting things about working where I work is I work across the street from the Eric Lindemann Center. And for those of you who may be familiar with his work, he was the person who did the research on the victims, the survivors and the family members of victims of the Coconut Grove fire. Okay, so this is a terrible tragedy where dozens of people died. And what he did there was the start of research that we would regard as PTSD research. And he came to see that as a normal reaction to these extraordinary traumatic experiences, there were some things that were so common to virtually all of the survivors and all of their family members. And telling this to people who may be rape victims, victims of events like yesterday, has turned out to be one of the things that people will grab onto as a source of comfort. So I'm happy to share it with you. And it's basically that the normal includes waves of somatic distress, intrusive thoughts, interruption sleeping, alternating with periods of psychic numbness. He also found, interestingly enough, two other things that these are some of the few things that people have ever written to me and said, I'm really glad you mentioned that, because when it happened to me, I would have been really worried. Okay? One of them was that everybody, whether they were frozen and rescued by somebody else, whether they were the people who ran out or who rescued the people who were frozen, that they often were searching for a way to find themselves responsible. Everybody would say, well, if only I had said to, my son, brother, friend, to do this or not to do that. Somehow making oneself experience responsibility is a nearly 100% human reaction. And then the last and probably the most valuable is that everybody had something that we would all in psychiatry immediately recognize as a kind of paranoia, which is a sense that people really had an awareness of us and everything going on with us when actually they didn't. And in the case of the people who went on to have gradually dissipating symptoms, most of them didn't really latch on to that paranoid kind of sense. But the ones who went on and really had a persistent traumatic syndrome, they were ones who started to think they must be going crazy. And not knowing that that's part of normal, not knowing to expect that you may have all the symptoms that we would regard as a panic attack, or Lindemann described there, people often having this sense that they're needing to curl their toes. Any of these weird things coupled with that paranoid sense, that's something that we can inoculate people about. And I think it's really one of the most helpful things to do.
Thank you very much, Dr. Sachs, on that. What we're doing this morning is we're organizing. If you're interested in volunteering, you can go through the Red Cross, and we can get you that link of the person who's responsible for organizing any relief for people traumatized by an event like this. Later this afternoon on the Mass Psychiatric Society website, there'll be a whole list of resources available, just as simple as thinking about families, how to counsel children, stuff like that. So that's being up and getting ready to go. So next, we have an educational program on May 2nd, Living with Bipolar Disorder, working through our Suicide Prevention Coalition. Do you want to just mention a few details, Sarah, about that?
If you're interested in attending this 43-minute film on living with bipolar disorders, this is going to be open to everyone in the community. The event is filling up fast. Dr. Sable wanted to incorporate this as a Psych MDPI for that Thursday, so a lot of you have your time blocked off already. And then after the film, there's going to be a panel discussion. So if you can come, that would be really great. For those of you that may not be at BMC, there's also going to be a film showing on Wednesday, May 1st from 9 to 11 o'clock at the Beacon Cinema. So that's happening. And one other thing that's going on is on May 23rd, there's going to be a Depression Screening Day, which is going to be 8 to 4 p.m. For anyone who would want to be screened. Again, this is going to be open to the community. and we're going to be putting an ad in the Eagle, so hopefully we'll get a good turnout.
Another announcement, thank you, Sarah. Another announcement we got on April 10th, John Meehan and Rizwan Iqbal, Dr. Iqbal, presented the depression screening process that we have in place for medically ill patients and the Depression Care Manager Project to the Be Proud series for the health system. That went extremely well and was very well received, so we want to thank Rizwan and John and Brenda and Sarah, who were all part of that effort. Thank you very much. Another announcement, we have a letter of intent to come and work with us from Dr. Allison Werner, who's going to be joining us on August 8th. She is a very talented graduate of the SUNY Upstate Syracuse residency training program. She's going to be working on the acute services at BMC, doing primarily partial hospital, McGee Recovery Center consultations, and primary care outreach team. So it's a very talented psychiatrist joining our staff. We look forward to that. Next, we're going to shift into just a we're going to have the grand rounds, and after, for those of you who stay, Dr. Sachs will be doing a case with Dr. Iqbal on how to apply some of the informatics that he's going to be talking to us about to help in the actual care of patients with bipolar disorder. So there'll be a clinical case illustration at that point with de-identifiers for the patient, but Dr. Iqbal presenting, so you can stay after grand rounds. Let me introduce Dr. Sachs, so you can see already, and just extemporaneously, he's right on the money and sort of knows just what we need to know. And we are very, very fortunate to have him here with us today. Dr. Sachs is one of the leading researchers in bipolar disorder, really coming from the great tradition of clinician researchers. And so we're very lucky to have him here today. I'll tell you a little bit more about him just so you know, and then he'll jump into his grand rounds. He's the Associate Clinical Professor in Psychiatry at Harvard Medical School, a psychiatrist at Mass General. Dr. Sachs is the founding director of the MGH Bipolar Clinic and Research Program and a therapeutic area leader at Bracket, a division of United Biosource Corporation. He'll talk about his disclosure issue in his presentation. He earned his medical degree at the University of Maryland School of Medicine. He interned in family practice and psychiatry at the University of Maryland Hospital, Baltimore, was a resident in psychiatry and chief resident in acute psychiatry at the Acute Psychiatry Service at MGH, one of the top acute psychiatry services in the United States. He served as principal investigator of the National Institute of Mental Health Systematic Treatment Enhancement Program for Bipolar Disorder, the STEP-BD research, the largest treatment study ever conducted for bipolar disorder. He's the principal investigator for the Cohen Family Foundation study, Inflammatory Markers in Bipolar Disorder, and the Erdman Fund study, Interventions for Ineffective Complex Chronic Care. He chairs the Scientific Advisory Board of the National Alliance for the Mental Illness and serves on the Scientific Advisory Board of the Depression and Bipolar Support Alliance. He served as co-editor-in-chief of the Clinical Approaches to Bipolar Disorder and the editorial boards of Current Psychiatry, Medscape, and Psychiatric Disorders Review, among numerous others. He's authored over 200 articles, abstracts, books, reviews, and book chapters. He's received many awards, among them a Thuron Scholarship, a Dunlop Award for Psychiatric Research and Writing, a DuPont Warren Fellowship at the Harvard Medical School, and the Mass Psychiatric Association Research Award. He's recognized as a top doctor by U.S. News and World Report. He's a distinguished fellow of the American Psychiatric Association, a member of numerous scientific societies, including the International Society for Clinical Trial Methodology, American Psychiatric Association, and American Association for Advancement of Science. As a recipient of an NIH Small Business Innovative Research Grant, he founded Concordant Rater Systems and holds patents for methods to improve endpoint reliability in clinical trials. He currently focuses his work on clinical trial methodology, innovative approaches to clinical practice, and patient-centered research. We're really fortunate to have him here with us today. He's going to present.
That very kind introduction. It's a pleasure to come out and talk to you about a topic that is really been a long journey for me. And despite that very long introduction, it doesn't start at the starting point. And I always have to fess up to what the starting points were. And there are really two that I should share with you. One, when I was just 15 years old, and I had a wonderful day in high school where we had two field trips. The first was to the county seat where the one and only computer existed. And everybody there, when we got there, was so excited because the room that housed the computer was about this size, and you know, you could barely walk around the edges of it. They were all excited because they were going to get a computer that was a third the size and twice as powerful. And everybody was really excited. I certainly was with all my piles of punch cards that I had brought to the center. So we go back to the bus, we go back to school, and then I get on another bus and I go out to the State Psychiatric Hospital, in a place appropriately called Sykesville. I had definitely thought about being a psychiatrist at that point, but I was really there because a young woman who I was interested in was volunteering and thought that I might come along. So of course I came along, and if there was ever a day I thought I wouldn't be a psychiatrist, it was that day, because there were close to 5,000 patients at that hospital. And you had to walk through these cottages, which were separate wards where the patients were. And in those times, patients stayed in the hospital for years. They were often very frightening. I saw people standing in pools of urine, banging their heads, shrieking, and I was thinking, you know, there are probably easier livings than this. And I was definitely planning to either go into becoming a football player or maybe an astronaut at that time. They both seemed like they would definitely be easier than psychiatry. But much to my surprise, when I got to the nurse's station, the staff was just as excited as the people at the computer center. And why? Because they were going to get a new treatment. And they were excited about it. That treatment was called lithium. And the people who I'd walked past who were so frightening, so clearly ill, and had been in the hospital for years and years, I got to see some of them discharged within 2 to 3 months. And it was a really very exciting kind of thing. So you heard that I went on and actually did my psychiatric residency at MGH. The next important point in bringing me here today happened at the end of the residency. I had always gone to talk to my supervisors, and of course, being a young guy at that time, my memory was pretty sharp. But toward the end of the residency, I realized that maybe it wasn't as sharp as I thought, and that my handwriting was pretty bad, and that maybe if I was going to be legally responsible for keeping notes with these patients, I ought to do it in an organized way. And we started making paper forms to keep the notes on. Now that was pivotal because it led to that big NIH grant that we got, $26 million, that basically came from the fact that we were able to show pilot results. Because when you keep records in a systematic way, you can actually harvest the outcomes. And once you know what the outcomes are, you can try some things to improve the outcomes, right? And that really is critical. Having bad handwriting has turned out to be the single best asset of my career. But I go back to that time when I started to use the computer, and computers have gotten a whole lot better. But the clinical landscape remains a very big challenge. And I'd like to start the discussion with this slide. This is actually from our colleagues in the UK. Jan Scott presented some data from the National Health Service where the psychiatrists there actually said, and this really made me feel good, I always show this to my boss at MGH, that as a nation, they feel that the hardest condition to treat is bipolar disorder. And whenever I want to raise, I've tried out the data from this study. It's never worked yet, but I always try. But I show it to you for what's at the bottom of the slide. When they listed the obstacles to stability, notice what's on the list and what's not on the list. It's chaos in the life of the patients. They often have multiple co-occurring conditions, so-called comorbidity, especially substance misuse. Believe it or not, a lot of patients there, just like here, don't accept their diagnosis. They often are non-adherent with their medication, and there are also a lot of issues with pregnancy. This list actually went on for 20-some things, and not in the top 5 and not in the top 20 was there any listing of, I need a different medicine to give people who have mania or depression. We're not challenged by knowing which medicine to give. We're actually much more challenged by this other stuff. And of course, it would be great if I could just tell you you need a lot more information, but you can see that that's a losing game too. I love this quote that if we read 2 articles every day, which is about 2 more than I tend to average, at the end of the year, you're what is it, 82 centuries behind in your reading. And maybe some of you will catch up. I've given up on that one. So that brings us to the topic for today, because computers can actually be helpful for this in a number of ways, but they're not helpful all by themselves. They really need to be part of an integrated paradigm that I think is useful to think about. So I'm going to give you a quick overview of some of the important things here by way of introduction. I'll show you our paradigm or clinical care schema, and then we'll talk about workflow that uses the computer to reduce the burden on you in particular, and how that can produce measure-based guidance to make decision-making better and easier, and then we'll hopefully come to some conclusions. This is my disclosure. The main thing that you should know is that the Collaborative Care Initiative is my private practice, so I have all the shares or equity such as there are, and there are a bunch of other things that I think Alex actually mentioned a lot. Bipolar disorder really is a common chronic condition. It's very interesting. It's certainly an equal opportunity illness. And here's where I start to show you something that I'm going to come back to, because it is generated by the computer. What you're looking at here is the course of illness for a patient. The blue line is the monthly ratings that they made on the Montgomery-Åsberg Depression Rating Scale. And the red line is the Young Mania Rating Scale. So you may look at this and you may say, oh, it looks like this patient might actually have had 3 episodes of depression. Maybe they have, but the more interesting thing about this is this third line. This is the quality of life measure that's used in many research studies called the Quality of Life Enjoyment and Satisfaction questionnaire, or QSQ. And it's interesting, what you can see, it's not every single case that I think is this clear, but in fact, the vast majority of them show exactly this pattern. And that is that the quality of life is really impacted by recurrences and has this kind of inverse correlation with depression. Right? You can see how clearly they go together. And in fact, if you were looking at the red and blue line, you'd be more struck by the fact that there's a bit of following of the red line with all the peaks in the blue line. So you can learn a lot from this. And I think it's important to understand that most of the suffering, in fact, with bipolar disorder, even though the cardinal feature is abnormal mood elevation, most of the suffering and disability is about recurrent depressions. So it's a really important thing, but I want you to start thinking about this kind of a graph. Is called a spark line graph. I think it's important in managing patients. So nothing could be simpler than making a diagnosis, and you all know what the DSM-4 has for the diagnostic categories. What's sad is that there's a lot of controversy about diagnosis of bipolar disorder, right? Some people will tell you that it's underdiagnosed. Some people tell you that it's overdiagnosed. And no matter what side of this debate you're on, you should agree that it's poorly diagnosed. And there's no real good excuse for that. I think we have sometimes fallen in love with screening measures like the MDQ, Mood Disorder Questionnaire, and used that as a substitute for diagnosis, or sort of taking a name that tune approach. That, boy, I can see, you know, this person, oh, that guy's got a red tie. I think he's probably bipolar type 3.5. If Kiskel was here, I think that would be enough for the diagnosis, right? And that kind of approach is not helpful to patients. If they're going to see somebody other than a psychiatrist, other than a trained psychiatric social worker, other than a psychologist who's specialized in this field, maybe. But as a rule, I think we are patients of formal diagnosis. Now, even when you make a formal diagnosis, some of you may have seen in the Green Journal just a month or two back that we have this test-retest reliability of the DSM-5 criteria. Any of you see that? I'm going to show it to you. Maybe some of you are 83 centuries behind. I'm pushing for 87. So they looked at the test-retest reliability of these common diagnoses. They actually looked at a lot more, but these are some of the best. And interestingly enough, the idea of test-retest reliability, here's how it works. You come up with a diagnosis, and I see the patient very soon after. What's the chance that I agree with the diagnosis that you come up with? Okay, so if you say it's bipolar, major depressive disorder, schizophrenia, borderline, whatever, what's the chance that that second grader agrees? Well, interestingly, they show the results that are pooled across several of the centers that did this. And they did this using structured evaluations that used a computer assessment, much like what I'm going to show you, to gather a lot of information, and they let the clinicians see it before they saw the patient and did their assessment. I don't know how much attention they paid to it, but it's actually a very nice way to practice, to let the computer do the grunt work. You look at it and then proceed, right? So it's kind of nice. Bipolar had the highest test-retest reliability, but there were two centers. One that was the Mayo Clinic, where they have some excellent psychiatrists. The other is San Antonio, where you may know Charlie Bowden's work. He's there. They certainly are a well-known center for bipolar disorder. How did those two centers do? Well, the Mayo Clinic did very well, and San Antonio did very poorly. So there was a almost 75% chance that if one person at Mayo said the person had bipolar disorder, the next clinician said yes. But in San Antonio, the chances were less than 25%. So this is kind of embarrassing to the field, but at least it's not embarrassment limited to bipolar disorder. There was one good MDD center, one terrible MDD center, and you can see that by and large, for major depression, we do terribly in terms of iterative reliability, test-to-retest reliability. Borderline turned out not to be so bad. GAD, there was only one center, and that was also pretty bad. Now these are among the most common diagnoses we do. And again, these are people who signed up for it, trained for it, prepared for it, and got a common set of information before they started. So this may be as good as it gets, but it's still not very good, is it? That leads to the next question. Doesn't matter. Doesn't matter. You could call the patient schizophrenic, and I could call them manic, or you could call them major depression, I could call them bipolar. Does that matter? Well, one of the things that we've been able to do with a computer is pair it up in tandem with a site-based rater. That's what this SBR thing is. And these are results from a Pfizer-sponsored global clinical trial where all the patients were randomized to add on ziprasidone, an approved treatment, FDA-approved treatment for mania, or placebo to their currently ineffective lithium or valproate. And there was a low dose of ziprasidone and a higher dose of ziprasidone. But the real point is everybody was eligible according to the site-based rater. And the high confidence, the green bar, is where the computer said, yes, I think they also have the diagnosis. And the gray bar is where they do not. And what you see, this is something that I will bet dollars to donuts you see in your practice, and that is the patients who didn't really have the high confidence diagnosis, they did better on placebo. That's a stunning thing, especially when you think of the trillions of dollars that are spent on healthcare and the high expense of maintaining people on useless medications with bipolar disorder. If we could stop doing that, it would be extremely helpful, right? We could get people in and they would do just as well without some of these very expensive treatments. And again, this is not a finding unique to this one study. I could show you 7 of the last 7 global trials that we've done. When people don't have a high confidence diagnosis, they do as well or better on placebo. Worse kind of thing. So how can we do better? Some guidance here for best practice. I think the 3 big things. One, I mentioned the formal assessment, both of current clinical status and of lifetime illness. So you may have bipolar disorder, but are you ill now? And if you are, what flavor of episode do you have? There's a lot about the model that we use that's problematic. We use a model of care that is great if you have tuberculosis, pneumonia, broken bone. It's an acute care model where we aim for cures. Chronic care is really very different. And I think being conscious of the kind of model that you're using and setting appropriate goals allows you to be much more successful. Otherwise, it's very frustrating for everybody. And then the other of these pillars that I think is really important is this management that we call collaborative care, where you're really working collaboratively, in this case, with the patient, and high priority on the therapeutic alliance. So I think it's wonderful to say, do all these things that are mom and apple pie, but in this case, the real good news is this has been shown to work. This is actually from the most recent Green Journal. And what you can see here is that in a randomized controlled effectiveness trial, where sites were randomized to, okay, here are the principles of collaborative care, go ahead and do it, versus having some central guidance for this, where they used measures. Everybody was allowed to use measures, but in the central guidance, they actually, through telemedicine, did these assessments systematically with all the patients. And what you can see is that it was extremely effective. Now, this graph may not capture it for you because it looks like a lot of other graphs, but let me just tell you the numbers in terms of response, getting 50% better, remission, getting nearly all the way better. It was about almost 8 times better to have the collaborative care with the telemedicine and really have somebody do this with the patient. And then in terms of getting all the way better, it was nearly 13 times the effect. So those are huge effects, and I think you're going to see in the public policy realm, this is going to start to have traction, especially as we have more and more accountable care organization type progress going on. So why aren't we all doing this? Well, I mentioned the lack of the appropriate model. We really don't have a great schema for personalizing care, even though it's what most of our patients want. It's great to look at the literature, and even if you could do more than 2 articles a day, you start to realize that that literature is written often about patients that don't look anything like the patients who come to our offices. So you get frustrated there. And then the last is this lack of time. Now that, to me, is probably the biggest problem. I don't know what the allotment is. How often do you, how many minutes do you get to see an outpatient when they come back for a routine follow-up? 15 is the modal time. We can do 20 mostly, and the sad news is there are a good number of places where 10 is what's being done. But let's just assume that it's at all these different kinds of places. You might be able to do 15-minute follow-up visits. What you have to fit into that time is really extraordinary, right? You're going to prepare for the visit, so Mrs. Jones is coming in, I have to engage with her. I need to do my assessment. I need to offer an intervention, have it be accepted, and then I have to write a note. That's a pretty tall order. And it doesn't leave much room for these other things like formal measures, education, negotiation, coordination of care, right? There's just no room for this stuff. And what happens when you can't do those other important things is that we have a lot of frustration, costs, and bad outcomes that are attributable to just not doing what the Institute of Medicine and many other organizations say we ought to do. So, you know, part of what is attractive about the computer is it can help with this kind of problem. Now, another aspect of it is wait until January 1st, 2014, because under the Accountable Care Act, the estimate is at least 32 million extra people will be in the lines at our offices across the country. So whatever was bad now and your allotment of 15 minutes, I'm not sure it will keep being 15 minutes. I think there's going to be a lot of pressure to do things even faster than what we've been doing. Now there's also going to be a reward if you can do this well. Under CMS rules, the Center for Medicare and Medicaid, they're going to let organizations that do this well keep, depending on which program you sign up for, either 50% or 60% of what you save. So from last year to this year, if you can save money by doing things better, there'll be a big reward for that. So a big issue from our point of view then is to solve this time problem. And you know, I love the laws of physics. You know, matter can't be created or destroyed, but every day we have opportunities to create and destroy time, which is amazing. Now, in the usual office visit, the workflow, we sort of looked at it a minute ago, but the workflow might have these three phases. There's a sort of before phase, the pre-assessment, and that may be that you look at your last note, right? Is that a typical thing to do when you're going to see a patient? Let's just see what I did last. You open it up, look at the last page, and look at maybe the assessment and plan, and you're ready for that patient. That can take almost no time. But during that office visit, remember, we have those tasks. We have to engage, assess, choose the intervention, educate them, etc. And then after the assessment, we have to document the visit, either on paper or now electronically. It would be very impractical to add anything like the formal measures in here. If you thought you would like to try to do this, and you're going to say, well, you know, I've been trained to do the Hamilton Depression Scale, or the Montgomery-Asberg, or the Hamilton Anxiety Scale, each of those scales can take 30 minutes or more by themselves. So adding that in here could really make it take forever. And we actually tried to do this. We had our staff doing these formal scales with patients before they saw us. It made all the patients late, all the doctors hated it, and we had to abandon doing that. So what we're proposing is to use the computer to get the pre-assessment done ahead of the visit. You could also use paper, and I'll come back to that. But by using the computer, in addition to looking at the last note, I can actually see how the patient is this week, just before they're seeing me. And we'll have our clinical schema, which I'll show you in a bit. And then we can actually use the computer to pre-populate a so-called smart template, which forms my note, because I can then edit it. So I don't have to copy over everything the patient has said. It's kind of there for me, which makes my life a little bit easier. Okay, so I'm going to shift from that introduction to the schema. Now, the idea here of delivering personalized care is certainly the flavor of the month, right? Everybody is all for personalized care. We would love to be able to do this. And we end up talking about algorithms. Well, if you offer to treat people with an algorithm, you will find that it's not at all attractive to patients. You'll find it's not at all attractive to doctors. or even to family members. Nobody wants to be treated by the national or international or even a state algorithm for anything. What they want from all of us is our expertise and judgment applied to them, right? That's the trick. How can we actually deliver individualized care to patients when all we're looking at is population-based data, for example, or following national algorithms? And it's not so easy, but you can see here that the first piece of it is shifting to this chronic care model. And the main difference between an acute care model and a chronic care model is that we're not offering the patient a cure. I haven't cured anybody's bipolar in the 40 years I've been at this. I haven't seen anybody else cure a case of heart disease. I haven't seen anybody cure diabetes, asthma, any chronic disease. So the goal becomes, instead of a cure, increasing the rate at which the patient and you make wise decisions amicably. And here's our model in words. A for concordance, make a formal diagnosis, formulate what I'll tell you about in the second, a so-called menu of reasonable choices, integrating measurement into the management, and then use this collaborative care approach for shared decision making. Now, I don't do well with words, I'm better visually. So here's the way it works. We start with a critical decision. Are we treating depression? Somebody who's rapid cycling? Are we trying to taper off somebody who's got maybe toxic polypharmacy going on? Whatever it is, we're going to formulate this idea of a menu of reasonable choices using these two bits of information. Our fund of knowledge about what's been proven to work for their condition, preferably, and then what we know about the patient as an individual. We then offer the patient always more than one, but less than 5, so it's 2, 3, or 4 options that we, in our clinical judgment, think is best for that patient at that time based on everything that we know about them. Okay? So that's how you formulate a menu of reasonable choices. You have to do some education negotiation, choose the intervention, the patient chooses the intervention. And here's where the magic is, because you're going to integrate in measures, and they're just some very simple ideas here. Right? If a treatment is working, what should you do? Continue that treatment. If the measures say the treatment isn't working, what should you do? Change the treatment plan. And what we're trying to avoid are inconclusive outcomes. Because when we get that, we have to walk back through this bottom part of the cycle where we have to renegotiate, do the intervention, say, I'm sorry you didn't take it long enough, you didn't take a high enough dose, whatever the problem is. But it's important to understand that if the patient can't stand the treatment, that's not inconclusive, right? So good response, poor response, intolerance, those are all conclusive outcomes. And then when we're seeing the patient back, at the very least, we have now grown what we know about them as individuals. And when we revise our menu of reasonable choices, right, it's now obviously personalized to them. And it gets progressively so over time. Now, how do we know what a proven treatment is? Well, there's a ton of great guidance out there, and evidence-based mental health is really a great source. And I'm just going to give you a shortcut into what it is, because I showed you how it's rated A through F. All I'm really asking you to remember is the definition of a category A treatment. These are treatments that are double-blind, placebo-controlled trials with adequate samples, not somebody's published study of 9 versus 11 patients. These studies, by and large, all have 100 or more subjects. And when you're getting 83 centuries behind, the quickest way to get ahead is don't feel the need to read anything with fewer than 100 subjects. And if you do that, you'll be practicing evidence-based medicine, and you'll have a lot less reading that you have to catch up on. Okay, so what would we see if we just limited to category A treatments? Well, for mania, we have lithium, valproate, carbamazepine, and a bunch of dopamine receptor blockers, right? What's interesting is that we also have a number of drugs that are anticonvulsants that been shown not to work. And you might look at this and say, isn't that interesting? There might be a class effect for dopamine blocking drugs, but certainly not for anticonvulsants, being antiemetic. Most of anticonvulsants don't work, right? So we're always going to want to offer the proven treatments first, select from what's on the left side if we're dealing with mania, the ones the patient hasn't had, or the ones you think are best, and make that your menu of reasonable choices. We can do the same thing for acute bipolar depression, and at this point, proven treatments are lamotrigine, olanzapine, thiopine, lurasidone, and the combination of olanzapine and fluoxetine. Notice what's not working. A lot of atypicals haven't worked. Standard antidepressants haven't worked, whether they're used as monotherapy or as add-ons to lithium or valproate. So please, again, choose something from the left-hand side. Individual factors. Now, I hope it came across when I showed you those last two slides that the list of proven treatments is short. The list of individual factors, things that have been associated with response in patients, it's actually very, very long. But I just want to say a little bit about how we use this. The single most useful one is the patient's response to prior treatment, right? So we can get that retrospectively. We create in every patient's record a chart like this. The adequacy of the dose and duration, an efficacy outcome, a tolerability outcome, and then overall. So you can see here, was it inconclusive, effective, intolerable, ineffective? Okay. And that's clearly what we're looking for, is to drive the decision making based on these outcomes when we formulate that menu of reasonable choices. So it's very nice to do that retrospectively, but you can also do it prospectively. So here is the next gold nugget that I'd like to share with you. This is from Joe Calabrese's group in Cleveland. And it's actually a much more intricate chart than I made here. And we're looking at all of those pivotal trials that I just showed you for bipolar depression. Some were positive, some were negative. They had placebo arms. Really interesting kind of stuff. But we could look at the positive predictive value and the negative predictive value of early response. Early response is a 20% improvement in 14 days. Now, what I really want you to pay attention to is this, but again, I do a lot better with pictures. So here's what I'm showing you about negative predictive value and positive predictive value of remission. Remission is getting the score down to something that's actually close to what the average non-ill patient would have if we interviewed them at a mall on a Sunday morning with one of these rating scales. So they're really well. If the patient had that 20% remission, and you can see for each of these treatments, they're all in the same neighborhood, right? It's about 40 to 60% chance that they'll have this great outcome at 6 to 8 weeks. But more importantly, if they don't have it, that's what the blue bar is. You can see we're 75 to 90% chance that at 6 to 8 weeks, that patient is not going to be doing well. Now, I'm showing you this for bipolar depression. I could show you identical data for unipolar depression, for treating anxiety, for treating schizophrenia. The list goes on. This is a near universal finding at this point, and that is that there's a very, very high negative predictive value of not getting even 20% better in the first 2 weeks of treatment. That's 2 weeks of getting to the right dose. Okay. So if you said, oh, I've got to tape, I'm going to titrate up over months, different story. But if you say, well, we got to this dose, and you know what, I saw some people did better after 16 weeks, and I look at the literature, it can be very confusing about how long a trial needs to go before you do something. If the patient isn't 20% better in 2 weeks at a given dose, raise the dose or change the treatment. Is really what this is telling us. Again, a very, very simple-minded idea, but one that can spare patients a lot of suffering. So you can see how this worked. Here's another patient, Mrs. A, she's a 48-year-old woman. I'm giving her lots of different things, and you can actually see her quality of life is pretty low. Her depression score This range between 20 and 40 is where most people in studies, if you sign up for clinical trials, you're almost always having scores like that. Same actual range for the YMRS, and you can see we get here, and now her mania score has picked up. So what am I going to do there? Well, what I did here was add, in this case, it was aripiprazole for this lady. And it's interesting, you can see a very good response here, and we just stay with it. And remember, aripiprazole was not on that list of approved treatments for bipolar depression. I probably wouldn't have started it here if it weren't for this blip up. But what's happened is both sides of the illness have responded. I can tell you that that's also something that is quite typical for bipolar patients. Obviously not everybody, but when you get a patient better, they do tend to get better with both sides of the illness. So applying that rule of continuing what works, we would leave this patient on aripiprazole, watching over her for as long as she stays well. Okay. Now another important aspect, I mentioned this managing the therapeutic alliance, and a key concept here is this idea of concordance. You know, we used to talk about compliance, and then it became fashionable to talk about adherence. Concordance for some people sounds like another fluffy, soft kind of word, but I think it's really critical to understand, because concordance is the extent to which you and the patient are actually in agreement about what's an appropriate treatment plan. Okay? That's different than adherence, whether the patient takes something or not, and I think this turns out to be something that leads you to this kind of 2-by-2 table. When you see patients and you divide them into whether they're concordant or discordant, adherent or non-adherent, it actually directs you what to do with that patient in the office. Right? We don't have to worry too much about those who are concordant and adherent. If somebody is in agreement with the treatment plan and they're non-adherent, this is absolutely the low-hanging fruit. These are the kinds of patients who, when you suggest any forms of external supports and you arrange them for the patient, they're grateful, they do well, and they get better. When you suggest external supports here, it doesn't work out that well. Okay? Why? Because the patient doesn't agree with it. The story I always tell is, you know, when I went to the APA meeting where they had on the meeting exposition floor, you know how you can get your blood pressure and your cholesterol measured at some of these meetings. You go in there, I had high blood pressure and high cholesterol some years back. I went home and, you know, my doctor thought I should take medication for high cholesterol and antihypertensives. And I didn't really feel like I should do that, so she let me do diet and exercise. And I came back 3 months later and I had the same blood pressure and cholesterol, and you know what? I hadn't really done that much diet and exercise. So it's not that surprising. And I pleaded with her, because I knew that I really thought this was important, to let me try again. And I kind of got lucky, because I heard on the radio in Boston an interview with the Boston third base coach at the time, a guy named Wendell Kim. Wendell Kim probably should have been a manager, but he was a bit rotund and never got interviews. And he was trying to lose weight. And he said he hit upon this great way to do it, which is when, you know, the team would go out after a game and they go to great restaurants where there are great desserts. He said, you know, I've really lost a lot of weight just by when I sit down at dinner, I say to all the people with me, if you see me having dessert tonight, I owe you $50. So I started doing that. It really worked great. You know, I lost over 20 pounds in a year just doing that one thing. Now the interesting thing is that, you know, I can go to dinner places in Boston, and people I don't know will come over and look when I'm with my family and see if I'm having dessert. I now have this huge collection of external supports, and we all laugh. But if you want to understand what happens with somebody in this box, I want you, the next time you're in a restaurant, look around for somebody who you think really shouldn't have dessert, and go up to them and say, you sir, you shouldn't be having dessert tonight. And realize that that's what we do with our patients all the time. We tell them what to do before we have achieved concordance. And this is a way to create a hostile adversarial relationship. We don't want to do that. If we're over here, we need to clarify there is agreement before we go on. Okay. So now we get into some of the pragmatic stuff here. And this key idea is collecting the pre-assessment. And I'm not real worried about how you do it, and you can do it on paper. Here's the paper, and you can go to our website and download these. They're just there for the taking. Waiting room form, patient fills it out. This is what I invented to control my bad handwriting. There it is. I can take what I get from that waiting room pre-assessment, and then I complete my symptom ratings, assign a clinical status, and I'm ready to create a menu of reasonable choices. Okay. So we've been doing this paper for a long, long time. The idea of a clinical status, this is really kind of fun because it's all based on DSM definitions that you know. I won't belabor the point other than to say that there are 9 of them. They're mutually exclusive. You assign one, and that's often connected with the treatment plan. Very simple. Now, here's where the fun starts. Directing the bipolar clinic, we always had this very interesting thing where nobody wanted to see new patients. And the reason was because taking on a new, particularly bipolar patient, is a major ordeal. Getting all the work done in the 1 or 2 assessment times that you have is no small trick. So what we've learned to do is create this pre-assessment on the computer. The patient does this at home. It can take them 2 hours. For me, I can review it, you can review it in under 90 seconds. That is a huge plus, in addition to the fact that it's going to get pulled into my note. But it's the same principle that we used with paper. It's just a lot easier with the way we can get the computer to display the information, as you'll see. So here's how it works prior to a baseline. There are 10 modules actually that the computer's going to do. It's going to ask about current and lifetime diagnosis, the formal scales, 13 common co-occurring conditions, history of prior treatment. It's going to create that nice chart that I showed you before about how patients have responded to prior treatments, the family history, the medical history, and a personality measure, which I absolutely love. I'll show you that in a second. I look at this report just like the people in that article from the Green Journal that I showed you when they did the test-retest reliability. Patient comes in for a visit. I know all this stuff already. Instead of interrogating them, I can talk to them. This really frees me to use my better skills rather than to say, what was the name of that medicine? Or, which side effect did you say you're having? So making the formal diagnosis, I offer a menu of reasonable choices, and we just get started. So that's lovely. Here is what the measures view of this looks like. And being a square-headed researcher, this is really exciting to me because that lets me do that 20% rule. Because I can see here's the MADRS score, Montgomery-Åsberg Depression score, Young Maynard Rating Scale score, this current week summary, which is really just like what was on that waiting room form that the patient filled out, but it's just pure self-report. These scores, by the way, are generated by the computer asking the next question based on the patient's answer to the prior question. So it's not really self-report. It's exactly what a human rater would learn to do. Here's our quality of life measure. Very handy and dandy to have that. But this is actually what doctors tend to like more. Because most of you, I bet, don't think in terms of those scales. So what the computer does is it crawls along and looks at all the rating scales. And for each of the domains that make up the depression diagnostic criteria and the hypomania diagnostic criteria, it shows you in a different colored bar for each of the sources that it has, where that would come out in terms of what you might think of as a kind of clinical criteria. Is it normal or none, questionable or rare, subthreshold for DSM? The blue line is the DSM threshold. Then you have severe and really constant and severe at the highest. Okay, so knowing that you need 5 of 9 for depression, does this patient meet the criteria for current depressive episode? Well, you know in a glance, right? You can just count how many bar is crossed there, it's only 4, so you'd say, not quite. But had they met the criteria at the last visit, they would still be counting as depressed now. So just kind of an interesting thing. Clearly, they don't meet it for mania. And also, you'll see that sometimes they hit it on something here, but the corresponding self-report was 0. So you realize that there's a lower degree of confidence when you have fewer bars hitting that threshold. Very helpful in making a diagnosis. That's for current diagnosis. For lifetime, we have an index of diagnostic confidence. It's really based on now more than 20,000 interviews that we've done with bipolar patients, using what Robbins and Goudet proposed as a way to assess the validity of any psychiatric diagnosis. So you have age of onset, course of illness, family history, response to treatment, and signs and symptoms. Now, DSM really just does signs and symptoms. But if you assign each of those 5 dimensions 20 points, you get a score 0 to 100. And again, in global clinical trials, having a high score has a high association with positive response to treatment. So it's a very good prognostic sign. The more this patient looks like a typical bipolar patient. The computer actually gives you an estimated score, and then you have a final score for each of those dimensions. So that's what it looks like. Here's our common co-occurring conditions. I see whether the patient has had a prior diagnosis, prior treatment, how many core features they have, and if they had any yeses, their age of onset. This is the personality measure. It's actually, this is data from STEP, showing you the typical pattern on the NEO 5-factor inventory, where we look at extroversion, we look at neuroticism, extroversion, openness, agreeableness, and conscientiousness. This is the profile that's typical for bipolar patients. For unipolar, it's the same, except that these two are actually low. It's really the difference. And knowing that the patient has a problem with conscientiousness or agreeableness at the beginning, and that I don't tell it to them, I'm just wondering aloud what it means when they score that way, very helpful for the therapeutic points. Treatment history, again, I don't have to make those charts because the computer has made it for me. Family history, the same kind of thing. Once we're past the baseline visit, we don't repeat all 10 of those modules. We just do 4. And if you stay for Dr. Iqbal's presentation, his patient, I think a couple patients who just did this, right? A couple days before the assessment, they do the MADRS, the YMRS, the quality of life, and that current week summary. And I follow them just the same way. And again, you follow that course. So the way this works, and again, if you're interested, you can go, and it doesn't cost anything. To have your patients do a trial thing, they can go to CCI Hub, ccihub.com. There's a trial thing. They can get the measures done. They can bring you the output in a report to your office. We call that self-care partner. The note writing that I showed you right now is not available unless I get you started with it. And so if you're interested, we can talk about that. But we have ways to match up what you can do with the computer to your level of engagement. So right now, if all you're interested in is, why don't I have my patients go and generate a report and they can bring it in, I'd be happy to look at it if they do. I can tell you the one thing that you can do that will blow that is don't look at it if they bring it in. That will make the patients very unhappy. But if you look at it, you'll see that it'll save you a huge amount of time and it will help you bring measure-based guidance in. If you're real interested in the rest of it, we're sort of at the level where for friends and family, we're letting people start out in exchange for feedback on what goes wrong. But the idea is to follow the Institute of Medicine recommendations, to be more patient-centered, to do better documentation, share it with the patient, share the decision-making, and integrate formal measures into care. So I think we have just gotten to the end. And what I've told you is that we start with a formal diagnosis. We do integrate those measures for better decision-making. There are a lot of ways you could do this, and I forgot to mention there are also a lot of mobile apps that you could use if you wanted to get measures that way. I think that's perfectly okay. This idea of creating a menu of reasonable choices lets you use the shared decision-making approach, and then following the care model. And making sure the patients are cued into this, improving the rate at which they make wise decisions with you amicably, I think you'll see that it works a lot better and your satisfaction professionally will be way up. So let me stop here and see if there are any questions that we can take. Yeah.
With meaningful use, patient portals are coming along
Yeah.
in the train, and everyone's going to have their own patient portal, and every EMR is going to have their
Yeah.
own patient portal. Have you thought about how to integrate these forms and this calculation tool with patient
Right.
portals?
Right. Well, it's an excellent point. So you don't want to be using, a system that won't work with the one required in your job. Right now, the system exports a PDF that many electronic systems will let you import, but not all. We are working on a kind of middleware that would actually populate the fields in some of the most popular electronic medical records directly from this. But there are a lot of issues and problems from the enterprise side, like in partners. They feel like that opens a security hole that they're not willing to tolerate. But they will let us bring in the PDF. So that's sort of an in-between solution. But eventually, I'm sure systems like this will talk directly to your record.
What about building and having the tools being right from partners' patient portal?
Yeah, actually, I skipped over a really important aspect of this. I didn't show you how the computer scores match up with the rater scores. Using a validated measure, you can do that. Right now, Partners does have some pure self-report scales that you can use, and those will match up. But they're not the same as the so-called objective scales that are typically used. And I don't know if they would work with the sort of 20% rule that I told you, because that's all used sort of the standard research kind of, quote, objective scales, like I showed. Other questions?
As you think about the world that Dr. Sachs is opening up, and you think about what we're currently doing, how do we get from where we are to where he's saying this is state of the art and we can do better care for our patients? Where are we kind of on track with what he's talking about? Where do we need to improve?
Well, at my supervision, I got a chance, Dr. Smothers introduced me to your scale, and especially with one of my very challenging bipolar patients. And as a resident, we take cases just for 1 year, so to build up that alliance, to meet the challenges of the illness, it was really very challenging. And Dr. Smothers introduced me that, sometimes patients are in denial of their illness, especially bipolar. And when we are sitting together, trying to come up with a shared decision making, the individualized part is not so much clear. We do have this background of what we know about clinically. So she introduced me as a nice way of engaging the patient so that they can look into the stuff and how are they sleeping and how are they doing, and kind of get some insight into the day-to-day things. And I think that was really helpful. And I was thinking of doing this with my patient, but she kind of moved on to go to her primary care physician. It was one of the difficulties, but I really liked it, and I thought it would be a nice tool to put it into the practice, especially when the engagement and the alliance is coming into play.
Yeah, I mean, one nice thing to do is to make it portable for the patient, so they can bring it to you and they can bring it to their primary care doc. Some of these are harder to do for us to be the ones who connect because of HIPAA kinds of rules. But engaging the patients in a way that gives them ownership of the information, I think you'll find that really is helpful. And when I talked about concordance and shared decision making, I glossed over a lot of things. And I don't want you to think that this is something I would do with a floridly manic patient, right? They're really are different kinds of care. When you're doing urgent care, that's driven by your responsibility to take care of the patient right then. All that I'm talking to you about is the vast majority of care we do that we would call sequential care. And that really is this idea of, you know, iterative revision of the menu of reasonable choice and including the patient in that, building concordance over time. You know, when patients don't agree with me, all I'm asking them to do is add the measure. And often they choose something that I don't think is that great a choice. If they will just measure it, I, without fail, pat them on the back and congratulate them. If smoking 2 joints and having omega-3 works, fantastic. But usually it doesn't. And when we see that it didn't, I'm really in a position where it's not me saying you're doing terribly. This is your report. And you know, borderlines aren't the only people who can split. Right? To say this, the computer seems to think you're really doing bad. What's going on here? Right? Before it thought you were doing good. So I think it's actually very, very helpful. And that's also, I didn't go into it about the NEO, 5-factor personality inventory. When a patient says that they have low agreeableness and low conscientiousness, that opens the door to you to have a discussion about putting in external supports. But if it's me saying, you know, you seem like such a disagreeable person, then I'm insulting you. It doesn't work that way, I think, when you have these computer systems. Other questions?
My sense of where we are is that we're a very strong system at concordance. We teach a lot about collaborative models, that kind of thing, but we could use measures more effectively, the upfront pre-assessment that you're getting the patient to help with, those kinds of things, and stricter attention to the evidence-based guidelines would all be areas that we could improve. And we have our special guest, David, you know, Albert, who's a nephrologist, the former medicine program director. He's our chief medical information officer. And he was kind enough to come today to sort of see how quickly could we get from where we are to the kind of world you're envisioning, you know. And,
however fast you can get there is the best you can do. Yes?
Your very first slide where you talked about what were the factors that get in the way of people doing well with bipolar disorder. Number one was chaos. And I wonder how, you know, how does that, when I think about my client caseload, I think that chaos would get in the way of them using this kind of system in many, many cases. So how do you deal with that?
Yeah. You know, you're raising the point. What if it turns out that 30% of your patients can't do this? I think you'll find out that it's a smaller percentage, but let's just assume that 30% can. Should we not do it because 70% will benefit? And in the course of my day, because that other 30% tends to make me late, and you know, the idea that I can know how to manage my time before the patient walks in the door because I've seen that pre-assessment, hugely beneficial. So there will be people who can't or won't do it. Many of my patients, you know, who don't have computers at home, because of the difference in the quality of the room with me, when I'm not having to interrogate them, they'll go to the public library to complete this because they can log on from anywhere. Right? They'll borrow somebody else's phone so they can do it on their smartphone. It still may not be everybody. Chaos is chaos, right? But it isn't everybody. And it still allows you to have a more gratifying practice and use your best skills for the other 70%. For some people, you know, they're so chaotic, we're going to end up basically asking a lot of simple questions. How many hours are you sleeping? You know, to me, when I ask that question, I know that so many minutes have just been drained from the universe. And I still may not know what I need to know. The computer is asked and it's presented to me in a very standard way. What's the most and least number of hours they slept this week, and a bunch of other things. So, to me, the rewards of it, even if it's not everybody, make it very worth doing.
so we're probably ready to switch over. One thing I was going to ask a quick question. I think Dr. Zay, he did it well. Did it well. Yeah, that's right. So we're going to present a clinical case study application for those of you who can stay. We're ready to move to the next phase. Thanks. Awesome.